So, as I always like to do, we're going to start off with a case. Okay. A 7-month-old HIV-exposed infant tested negative by DNA PCR at his 6 weeks of life. She was exclusively breastfed for 6 months. She presents to the clinic today for follow-up. Okay, what do you do next? Should you check the child's weight, check the immunization status, and then discharge the child from the clinic? Should you prescribe Bactrim and repeat the DNA PCR? Should you check the CD4 and baseline bloods? Or should you stop the Bactrim, monitor weight, give him a dose of vitamin A, and make sure he's had his dose of medicine for deworming? Okay. How many people like A? The child was HIV negative at 6 weeks, so we'll just check the weight, make sure the immunizations are up to date, and he's fine. How many like that one? Okay. So a few people are liking that one. How many people like prescribe Bactrim and repeat the DNA PCR? A few people liking that one. What about check the CD4 and do baseline blood? No, he's negative, right? He's negative. What about stop the Bactrim, monitor the weight, give a dose of vitamin A, and deworm? Don't like that one. Some people like that one. Well, go back to the facts. The child is now 7 months old. He only had one PCR done at 6 weeks, and it was negative. But the child breastfed for 6 months. So is the child HIV negative? Is the child HIV negative? We don't know. The test was done at 6 weeks. That was negative, but he was exposed through the breast milk, so he might actually be positive. So we need to prescribe Bactrim and repeat the DNA PCR. These are fine to do. You should check the weight, you should check the immunizations, but you shouldn't discharge from the clinic. There's no need to check the CD4 and baseline bloods because we don't know whether he's positive or negative. And we shouldn't stop the Bactrim because we don't know whether he's positive or negative. So she still needs to take Bactrim. Okay? So the correct answer, prescribe Bactrim and repeat the DNA PCR. So when we're talking about infant feeding options, really there's two main options. There's exclusive breastfeeding. And what do we mean by exclusive breastfeeding? It means giving the infant breast milk only. And we mean breast milk only. There are a few exceptions. You can give them medicines because he's going to need to be taking Bactrim. You can give them vitamins like multivitamin syrup. We also prescribe that. And mineral supplements. But that's it. So it's no juice, no water, no soft porridge, no formula. Okay? Nothing else but breast milk and possibly some medicines. That's what we mean by exclusive breastfeeding. What do we mean by replacement feeding? Well, replacement feeding really is anything else. It can be formula. It can be, well, rooibos tea doesn't have much nutrients, so hopefully you're not feeding an infant rooibos tea. No, I know they do it. I know. But anything else is replacement feeding. If it's modified cow's milk, modified goat's milk, formula, rooibos tea, hopefully they're not doing that, but we know they are. That's replacement feeding. If you're doing both, that's mixed feeding. If you're giving breast milk plus anything else, that's mixed feeding. So when talking about which is the best, which is better, you need to weigh the risks and weigh the benefits. So it's like a big scale. You're weighing the risk of HIV infection, and you're weighing the risk of death or other morbidity and other mortality. What are the risks? What are the benefits? Whenever you're talking about anything in medicine, particularly what infant feeding practice to recommend or what to tell women before they make the decision how they want to feed their child, you must first review the risks and the benefits. So, does replacement feeding, does formula feeding carry any risk of HIV infection? If the child is already negative at 6 weeks, does formula feeding give that child a risk of getting HIV? If they're exclusively formula fed, do they have a risk of getting HIV? No, they don't. If they're already HIV negative at 6 weeks, we know the child is negative, there is no risk of getting HIV through formula feeding. No, zero. Is there a risk of getting HIV through breast milk? Yes. Do certain things increase or decrease that risk? Yes. Okay. If the mother's on ARVs, that decreases that risk. If the child is taking medicine, like nevirapine, during breastfeeding, that reduces the risk. So there are things that you can do to increase or decrease that risk. Now what about death? If the child is exclusively breastfeeding, is he at risk of dying? Yes, he still could die. Is that higher or lower, that risk, than if he's formula fed? It's lower. It's lower. Children who are formula fed have a higher risk of dying. They have a higher risk of dying through diarrhea disease, a higher risk of dying through pneumonia, a higher risk of dying through malnutrition. Because breast milk was designed to be the right thing to feed the child. That's what it's for. That's how the body was designed. That's what breast milk was designed for, to be the optimal choice to feed the child. So it has the right vitamins, it has the right minerals, it has the right calories and proteins and fat for the child. Formula does not. Formula does not. And formula also does not contain a very important thing, and that's the antibodies from the mother. Breast milk contains antibodies from the mother that can protect the child from diarrhea, that can protect the child from getting pneumonia, can protect the child from other types of infections that no formula can provide, only breast milk. That's why the children who formula feed only have a higher risk of dying. Are there certain things you can do to decrease that risk in a formula-fed child? Yes, and we're going to talk about them at the end of this lecture. So what are some variations of exclusive breastfeeding? Well, in an HIV-negative mother, it's unlimited. The WHO says and actually recommends exclusive breastfeeding or breastfeeding for 2 years of life. Exclusive breastfeeding for the first 4 to 6 months, introducing solids at about 6 months of age, and then continuing breastfeeding through the first 2 years of life. That's what the World Health Organization recommends. Now there's early cessation of breastfeeding, and that's what we talk about in HIV-positive women. So HIV-positive mothers can stop breastfeeding at 6 months or earlier once a reliable source of replacement feeding is identified. You could also heat treat breast milk. So mothers can express their breast milk and then boil it. And that will kill the HIV and decrease the risk of transmitting HIV. There's not a whole lot of evidence about the benefits of heat-treated milk, but it is an option that can be done. What about replacement feeding? Well, there's commercial formulas. There's many, many, many different brands, many, many different varieties, even within the same brand, for different things. There's modified animal milk, cow's milk with fortifier, goat milk with fortifier. Okay, because goat's milk, cow's milk is not sufficient for a child. Goat's milk and cow's milk is sufficient for goats and cows, not for children. Okay? Breast milk was designed for children. Cow's milk was designed for cows. So if you're going to feed the child cow's milk, You need to add certain vitamins, certain amounts of actually sugar because it doesn't carry enough calories, and protein are actually different. So it's not the best thing to feed the child. Then, now it's not done very commonly here, but in other communities, wet nursing is a reliable source of feeding. And that simply means another woman other than the mother breastfeeds the child. So if the mother is positive and maybe has a friend or family member who's HIV negative, she could have that person breastfeed the child. That is done in some communities. I don't think it's done very commonly here in South Africa. So when a child is HIV exposed, exclusive breastfeeding during the first 6 months carries greater benefit than mixed or replacement feeding with respect to morbidity and mortality from HIV and from other infectious diseases. That is a fact. Many, many studies have shown this. Exclusive breastfeeding for the first 6 months has a lower risk of that child dying and has a lower risk of that child dying over mixed or replacement feeding. But breastfeeding carries a significant risk of HIV when compared to replacement feeding. It's less if it's exclusive breastfeeding, okay, because we know mixed feeding carries the highest risk of getting HIV and the highest risk of the child dying. Okay? So exclusive breastfeeding is less risky than mixed feeding, but it still has risks, like acquiring HIV infection. Again, you're weighing the risk of HIV infection from the breast milk, from dying from formula feeding. Okay? Because of risks of diarrhea disease, risks of getting other infections, and the risk of malnutrition. Okay? You're always weighing the risks and the benefits. In KwaZulu-Natal, actually mothers have a high prevalence. About 18% of women, their preference is mixed feeding. They prefer to breastfeed plus give formula. So they prefer to do the thing that is the highest risk of getting HIV and the highest risk of the child dying. This is what we need to counsel against. Okay. We need to counsel against mixed feeding because it carries the highest risk of the child dying and the highest risk of getting HIV. So in order to recommend formula feeding or replacement feeding, we mentioned several times in the PMTCT lecture, it must meet the AFASS criteria. So what the heck's the AFASS criteria? Well, these are criteria, 5 things that you must meet every single one of. You must meet every single criteria. If you do, then you can recommend replacement feeding. Otherwise, we recommend breastfeeding. Okay. So, if you're HIV positive and using infant formula or modified cow's milk, a safe and secure option for you, these are the AFASS criteria in pictures. So what does it stand for? AFASS. You can use replacement feeding. You can use formula if you meet all these 5 criteria. So is it acceptable? Is there somebody in your house, the father of the child maybe, or partner, who doesn't want the child to be formula fed? You say, but if you formula feed the child, everybody will know that you're HIV positive. So we don't do that in my house. Right? Well, then it's not acceptable. Or the mother herself says, you know what, I don't like this. I was breastfed. My whole family was breastfed. I think breast milk is the best thing for the child. I want to breastfeed. Well, then it's not acceptable to her. She cannot give the child formula. Is it feasible? Now, the comment we heard during the PMTCT lecture is lots of times it's not feasible because there's stockouts of formula. You can't afford the formula. The clinics are not having the formula reliably. Well, then it's not feasible. You can't do it. If you don't have proper running water, you don't have a tap in your home, and there's no tap near your house, Some people are fetching water from the rivers. Is it feasible? No, it's not. Is it affordable? If you can't reliably get it from the clinic, can you afford to pay for it yourself? If you are getting it from the clinic, if there's a stock out from the clinic, can you afford to buy it? Formula is very expensive. Very expensive. Is it sustainable? Meaning, for the first 2 years of the child's life, will it be around? Will it be available for the child to eat? Are there going to be stockouts at the clinic? If you go to a clinic, they never have stockouts. It's always there. There's a backup plan in place if there is a stockout. Well, then it is sustainable. But as in most cases, there are stockouts all the time. What's the mother to do if she goes to the clinic and there's no formula? How is she going to feed the child? The child's now at risk of getting malnourished, or the mother is at risk to trying breastfeeding again, and now it's mixed feeding. So it has to be sustainable. And it has to be safe, which means you have to have a safe water supply, ideally with a tap inside the home. Shared taps have a higher chance of getting contaminated, and as you're transporting water to and from using old unclean buckets, there's a higher chance of being contaminated. If you don't have facilities to boil the water at home, then it's not safe. If you don't have a refrigerator at home, it's not as safe as if you do. Then you can refrigerate the formula, make it ahead of time, make it easier. So it's not always safe. But if it is acceptable, feasible, affordable, safe, and sustainable, then we can recommend over breastfeeding. And when do you stop breastfeeding? Well, as soon as feasible, if we can meet these 5 criteria, taking into account the woman's individual circumstances on an individual basis, taking into account the AFASS criteria, the risks of replacement feeding have to be weighed. If still it seems like the benefits of replacement feeding outweigh the risks, you must have in place guidance and support for the first 2 years of life to assure adequate replacement feeding for nutrition purposes. Because at the time of weaning, when the child stops breastfeeding, they're at highest risk of getting malnutrition. Because breast milk was designed to be the nutrient source for the child. Cow's milk and formula was not. Cow's milk was designed by cows. Formula was designed by a company that wants to make money. Okay? Not for the health of the child. Infants in the post-weaning period are very, very, very high risk of malnutrition for many reasons. Maybe because we can't afford formula properly. So we give half the amount. So we don't give the proper amount of formula because it's too expensive. So we say, okay, well, we'll give half. Or because we don't know how to mix it properly. Different brands you mix differently. Some are 6 scoops in a cup of water. Some are 4 cups in a cup of water. It's different. So what if you're not mixing it properly? Or what if you're not understanding the directions how to mix it? It says 6 cups in 1 cup of water, and instead of in 1 cup of water, you do the whole bottle. Okay? All of these things I've seen. All of these things I've seen can lead to malnutrition. So the old recommendation, even from the old 2008 PMTCD guidelines in South Africa, and even the old WHO recommendation, said once a child has formula or replacement feeding, they should never again have breast milk. That was the comment from the front at the end of the last lecture. That's what everyone was told. That's what we're all telling mothers. Right? As soon as the child, anything passes the lips from the child, that's not breast milk, it's not medicines, never again breastfeed. That's what we've been telling them, right? How easy is that to do? I don't know how many of you have had children who breastfed. Both of my children breastfed, and it's very difficult to get them to stop breastfeeding. They want to continue breastfeeding, trust me. It's not easy. So if you just stop and say, okay, today's the day, April 23rd, today's the day, we're stopping breastfeeding. It's 6 weeks, child 6 weeks old, no more breast milk, we're giving the child formula. And he takes the bottle and he throws it back in your face. And it's not nice to you as a mom either. It's not nice for the child. It's not nice for the mom. It's not practical. Now, in research studies where it was very regimented, this is what you did and that's how it was, and you said you stopped at 6 weeks, and I'm sorry, yes, the kid cries, and the kid doesn't eat for a few days, and the mom gets very sore, and it's not nice for the moms, but that's the research study. It worked. And it worked very well. The risk of the child getting HIV in those circumstances was very, very, very low. The chance of the mom not actually doing that is also very, very high. At 3 o'clock in the morning when the child is screaming and screaming and screaming because he's hungry, and you try to give the child a bottle, and he refuses it, and he spits it out, and he throws it in your face, and your breasts are engorged, and they're very painful, you're going to take that child, and you're going to put him to the breast. And that's mixed feeding. And what we were told before is, now your child's going to get HIV, what you've done is terrible, you're a terrible mother, but it's not practical to do that. It doesn't mean the child will automatically get HIV. Does it increase the risk? It does. It does. But it's not practical to do this for the child or for the mother. Okay. So important points about breastfeeding. We're going to talk about what is recommended in the next few slides. So important points about breastfeeding. Children of HIV-positive mothers who breastfeed need to continue Bactrim prophylaxis until confirmed HIV negative. So throughout the time that they're breastfeeding, even 6 weeks after they stop breastfeeding, they should continue taking Bactrim. It's not something that's commonly prescribed from the clinic after the first few weeks.